Hi, my name is Holly, and today we'll be looking at the dissociative identity disorder. We'll be looking through the DSM-5, as well as some evidence-based research and a quick clip to get a better understanding of the disorder, how to identify it in clients, and hopefully we'll get some implications for future practice. Okay, so let's start with the DSM and explore what the DSM says about the dissociative identity disorder. So we'll start with dissociative disorders in general, kind of describe those, find out what symptoms of those might be, and then we'll drill down a little bit further, talk about dissociative identity disorder in particular, discuss the criteria, possible other diagnoses, comorbidity, and things to watch for. So a dissociative disorder is described by the DSM as the disruption or discontinuity in the normal integration of consciousness, memory, identity, emotion, perception, body representation, motor control, and behavior. Symptoms of this would be the unbidden intrusion into behavior and/or your awareness. And the second would be the inability to access information or control mental functions that are normally accessible. So dissociative identity disorder specifically comes with 5 diagnostic criteria. The first being that there are at least two or more distinct personalities present. The second would be recurrent gaps in all sorts of everyday events, traumatic events, important personal information, etc. The third would be these symptoms that you have would cause clinically significant distress in either your social life and/or, I guess, professional life. The fourth would be this disturbance is not better or otherwise explained by your cultural norms or religious beliefs. Side note here is that children that have imaginary friends, that's not the same thing. And then the fifth would be that this disturbance isn't otherwise explained by substance use. So a lot of research shows the DSM kind of backs this, and research we're about to look at in a minute will prove that dissociative identity disorder is usually the aftermath of trauma. So typically what you can kind of expect to be comorbid with dissociative identity disorder is depression, anxiety, substance abuse, self-injury, and that's a very important one for anyone working with a dissociative identity disorder client. The estimation of suicide attempts is up near 70% for these clients. So always something to look for when working with this population. But this population makes up less than 1% of the population, so not a huge number, but still very important to kind of understand how to work with these people. So the research we're about to look at will give us a better understanding of how to work with this population and these clients and kind of what works for them. But other diagnoses to consider when you're looking at dissociative identity disorder is major depressive disorder, bipolar, PTSD, psychotic disorders, personality disorders, etc. Okay, let's check out some evidence-based research. This was published in October 2015. And let's dig in here in hopes of gaining some sort of implications for future practice. As per the DSM, this article defines the dissociative identity disorder as the presence of 2 or more distinct personalities. And this research was really conducted in an effort to better understand what people living with dissociative identity disorder feel is effective in treatment. So they came up with 4 kind of key findings or key themes that we'll go into more detail about. The first being effective approaches and techniques. The second being effective relationship building techniques. The third being ineffective approaches and techniques. And the fourth being counselor qualities, both positive and negative. Okay, number 1, effective approaches and techniques as identified by clients living with the dissociative identity disorder. They identified 4 effective approaches and techniques, the first being the pacing of sessions. What that really means is just constant contact and continuous contact with the same therapist or counselor. These are not people that you want to cancel on. These are not people that want to be moved several times or rescheduled. They really benefit from having constant and secure contact with the same therapist. Number 2 would be the secure structure. That's just the connectedness that the client feels, the groundedness the client feels to the therapy sessions. The third being support group. This was an interesting one because all of the counselors reported being initially very hesitant to send these clients to support group. They felt that maybe the support group would kind of reignite any trauma from their past, but all of the clients that went to support group reported it being very helpful. So something to kind of just keep in the back of your mind is working with this population in the future, support group may be an option. Number 4, identifying and assigning these alters. So an alter is the clinical term for another personality. So by assigning or giving power to some of these alters, it reduces the power over the host. So those are the 4 effective approaches and techniques that were really resonated with clients living with dissociative identity disorder. The pacing of sessions, the secure structure, the support group, and identifying and assigning your alters. Okay. Number 2 would be effective relationship building techniques. 3 techniques were identified in this section. The first being self-disclosure. Of course, as you will guess, this should be used in moderation, but it has been noted that it helps kind of form a bond between the therapist or the counselor and the client. It kind of also provides a new perspective for these clients on how to manage problems, manage things, and it really made the counselor more real to the client. Less of a robot, less of a robot, just more of a real person. To kind of maximize the effectiveness of this technique, though, it should be used sparingly, as to not kind of take away the attention from the client, keep the attention on the client and make it a lot less about you, make it a lot more about them. The second being modeling behavior. So this is just needing explanations with the appropriate behavior. So if your client has made a lot of progress, enthusiasm would be a really good emotion to kind of model for that client. If they are having a rough day, maybe some concern or some empathy would be good to meet them to kind of model some good behavior. The third would be the client-centered approach. So this is really the way in which we emphasize the individual and not the limitation. Just because someone is living with dissociative identity disorder does not mean we define them that way. That does not make them dissociative identity disorder. We do not put them in a box. We really emphasize them and get to know them as a client and not their disorder. Okay, so the third theme here is the ineffective approaches and techniques. The clients identified 3 approaches or techniques that would not work in therapy. The first would be inadequate termination. Just transferring someone or referring them, not having kind of the appropriate transference of a therapy session. This proved to have some pretty detrimental effects on these clients. They are people who know trauma, have experienced trauma, and we can actually set them backwards with some inadequate termination. So 2, relying on technique. So relying on your technique and not the therapeutic relationship, being a therapist that fully believes in the efficacy of one school of thought or one approach really didn't benefit the client and really didn't add to the therapeutic relationship. The third would be lacking a therapeutic plan. So having no clear direction or goals, not being goal-oriented, just kind of shooting the breeze, not overly helpful with this population. So the fourth theme here is counselor qualities, both positive and negative. The clients identified 6 qualities, 3 positive and 3 negative. The first positive was empathy. Second positive was unconditional positive regard. And the third positive was genuineness. And then there's 3 negatives. The first negative, lack of empathy. The second negative, lack of unconditional positive regard. And the third negative being not believing in the disorder. So that can really crush a process for sure. So now that we have some implications for practice, I'd like to provide a real-world example. The following clip was taken from USA Today. It is Christine from Washington. She has a confirmed 6 personalities. Take a look.
One more.
Sure.
Cut it out.
That is 2-year-old Cindy. The rest of the gang, as they're called, will introduce themselves.
Wait, I'm Christine.
I'm Chrissy. I'm Tristan, the lone male.
I'm she. I am Q. I do all the beats. I'm Rim.
Christine has dissociative identity disorder, formerly known as multiple personality disorder. It's recognized by the American Psychiatric Association and affects just a fraction of 1% of the population.
Well, I, of course, always get the play.
Who's my wife gonna partner up with?
I'll be the shuffler.
Doctors say Christine's brain got shuffled, fractured is the clinical term, when she was a little girl.
But I just seem to be going the wrong direction all the time.
And that's different from when?
Funny.
Oh, that's what I'm gonna do. Here, shebang.
That didn't work out well for me at all.
Christine suffered physical and emotional abuse from her father throughout her childhood and what can be politely described as torturous sexual abuse at the hands of a neighbor from the ages of 7 to 9. Her childhood, a cruel game of survival.
That was complete being imprisoned in my mind.
Drawings Christine did in therapy show the violent battles inside her head. Doctors say when the brain can't handle any more abuse, it fractures into different personalities, and each one often serves a purpose. Instead of Christine suffering the sexual abuse, Rim, a tough tomboy, would appear and absorb the shame. The alter She, a gruff 30-year-old lesbian, would come out and take on the abuse from Christine's father. But as Christine got older, the personalities that once protected her turned.
There's a little bit of a triangle scar from a tip of an iron.
Rim led Christine to the dangerous world of drugs and promiscuity. Christine waking in places with people she didn't remember. Alter She was the worst abuser.
And we have a scar on in our hairline from when she smashed a picture frame. She used to smash pots and pans on us, and we'd have really big gnarly bruises and burns. Burning was a big thing.
It went on for years.
It's so frightening to feel like you don't have access to your mind or can keep control, or that people think that you're a freak or that something's going on.
Thank you for watching. To review, we did 3 things today. The first thing we did was review the DSM and the diagnostic criteria associated with the dissociative identity disorder. The reason we did that was so that in the future we can be able to diagnose and identify this disorder in clients. The second thing we did was we reviewed evidence-based research. We did this to help provide us with tools or techniques to use in the future as a roadmap with these clients. The third thing we did was we watched a clip in hopes of tying it all together for you. Both the DSM and the diagnostic criteria, also the evidence-based research and how that might help clients with this disorder. Thanks so much for watching.